Hello everyone. Today we are going to learn the topic Neurocranial Nerve Assessment Part 1. I am Minoli, tutor of Triple M College of Nursing. Objectives of the topic: introduction, olfactory nerve, optic nerve, oculomotor nerve, trochlear nerve, trigeminal nerve, and conclusion. Understand what are the cranial nerves are there, what are their functions. So first, cranial nerve, olfactory nerve, which is responsible for sensory for the smell, and second, cranial nerve, optic nerve, which is responsible for sensory for vision, and third, cranial nerve is oculomotor nerve, which is responsible for motor fibers to eye muscles, and fourth, cranial nerve is a trochlear nerve, which is responsible for motor fiber to eye muscles, and the fifth cranial nerve is trigeminal nerve, which is responsible for sensory for the face and motor fibers to chewing muscles, and the seventh cranial nerve is facial nerve, which is responsible for sensory for taste, motor fibers to the face, and eighth nerve is for vestibulocochlear nerve, which is responsible for sensory for balance and hearing. Ninth cranial nerve is for glassopharyngeal nerve, which is responsible for sensory for taste, motor fibers to the pharynx. And the 10th nerve is for vagus nerve, which is sensory responsible for sensory and motor fibers for pharynx and larynx and viscera. And the 11th nerve is for accessory nerve, which is responsible for motor fibers to neck and upper back. And the final most, the last one, the 12th nerve is hypoglossal nerve, which is responsible for motor fibers to tongue. Articles required for the cranial nerve assessment: powder and soap, salt, sugar, Snellen chart, pencil or pen, cotton wicks, torch, tuning fork, tongue depressor, and two test tubes, one with hot water and another one is cold water, and safety pins, same thing, solid for grasping, sharp object like key, reading material to assess eyes, and language knee hammer and knee hammer. Cranial nerve 1, olfactory nerve. Before testing the nerve function, ensure the patency of each nostril by occluding in turn and asking the patient to sniff. Once patency is established, ask the patient to close eyes, occlude one nostril and hold aromatic substance such as coffee beneath nose. Ask the patient to identify substance. Repeat with the other nostril also. Normal findings of the olfactory nerve. Here, the patient is able to identify substances. Sometimes bear in mind that some substances may be unfamiliar. Deviations from the normal findings are: anosmia is loss of sense of smell. It may be inherited and non-pathological, or may result from chronic rhinitis, sinusitis, and heavy smoking and zinc deficiency or cocaine uses. It may also indicate cranial nerve damage from facial fractures or head injuries, and disorders of base of frontal lobe and such as tumor and atherosclerotic changes. Some persons with anosmia usually also have taste problems. Next we'll see cranial nerve 2, optic nerve. Here there is a three divisions of the test we are going to do. One is a visual acuity test and visual field test and fundoscopic examination. Visual acuity test. Use a backlit Snellen chart positioned at 20 feet, 6 meters, and dim the room lighting. Cover one eye and ask the patient to read the chart from the top and down until they cannot read any further. Repeat for the other eye. And near vision, use Jaeger or Rosenbaum chart, and handheld cord can also use to test visual acuity and the bedside. And hold 14 inches above the 30 centimeter from the patient eyes to check the Jaeger chart and Rosenbaum chart. Normal findings of the visual visual acuity test. So here the patient note that 16/6 is the regarded as a normal vision, and deviation from the normal one, deficits of the cranial nerve 2 deficits can occur with a stroke or brain tumor. Now we'll go for the visual field test. Here we are going to assess peripheral visual fields. So have the patient sit directly facing you at a distance of 60 to 90 centimeter, which means 2 to 3 feet. Ask the client to cover the right eye with a card and look directly at your nose, and cover or close your eyes directly opposite the client's covered eye, your left eye, and look directly at the client's nose. Hold an object, example pen light or any pencil or stick something in your fingers, and extend your arm and move the object into the visual fields from various points into the periphery. The object should be at equal distance from a client and yourself. Ask the client to tell you when the moving objects is first spotted. Repeat the above steps for the right eye, resolving the process. Normal findings of the visual field test. Here, temporarily peripheral objects can be seen at the right angles 90 degree to the central point of vision. The upward field of vision is normally 50 degree because the orbital ridge is in the way. The downward field of vision is normally 70 degree because the cheekbone is in the way. The nasal field of vision is normally 50 degree away from the central point of vision because the nose is in the way. Deviation from the normal findings are usually field smaller than the normal one, and possible like glaucoma or one half vision in one or both eyes is possible for the some nerve damages like retinal nerve, retinal detachment or something else. Assessment is fundoscopic examination. Here using the ophthalmoscope to finding the problems. So here to finding the optic disc shape and color, size and cup and retinal vessels and retina also to be checked using the ophthalmoscope. And what are the normal findings can be seen? If a optic disc round or slightly oval, optic disc is creamy pink or size 1.5 millimeter and symmetrical in both eyes, and physiological cup symmetrical both eyes occupies 4 by 10 to 5 by 10 of cup sizes. Arteries are light red, smaller than veins, and veins are darker. Retina is pink and a uniform color. Deviation from the normal findings of the fundoscopic examination. Papilledemia is seen in hypertension patient, increased ICP, or optic atrophy and optic nerve damage, and pallor not equal in both eyes, asymmetrical in both eyes, occupies more than 5 by 10 of cup, and pale and small arteries, copper or silver color in hypertension may be seen, and cotton wool patches seen in the hypertension patient. Now we are moving to the cranial nerve 3rd oculomotor and cranial nerve 4 trochlear and cranial nerve 6th abducens. Here the three nerves is going to work together and for helping for the eye movement and all the eye functions. All these nerves help to move the eye, hence it is tested together. The patient is asking has to follow the examiner's fingers as it moves horizontally and vertically, making it a cross, and diagonally making a X, like that, and checking for pupillary constrictions with the help of a torchlight. And convergence and accommodations is tested by having the patient focus on examiner finger as it moves towards the patient nose, and convergence eye turning inward. Extraocular movement. Here, assess the 6 ocular movement wagon wheel method to determine eye alignment and coordination. Here, the client must keep the head still while following the pen that you will move it several direction to form a star in front of client's eyes. Always return the pen to the center before changing the direction. Extraocular movement, normal findings are both eyes coordinated and move in unison and with a parallel alignment, and deviation from the normal findings are eye movement not coordinated or parallel. One or both eyes is failed to follow a pen light in specific directions. Example, strabismus across eye. And nystagmus is a rapid involuntary rhythmic eye movement other than at end point may indicate neurological impairment. Accommodation. Here, the adjustment of eye for vision distances. Hold your finger or object in the front of the patient from a distance of about 40 inches from the patient. Instruct the patient to focus on fingers or objects while you move finger or object closer to the patient. Note convergence of eyes and constrictions pupils as object gets closer. Normal findings of the accommodation. Convergence of eyes and constrictions of pupils to focus on the near objects and dilation of pupil when looking at the far object. Accommodations may be sluggish in advanced ages. It is very normal. And deviation from normal findings. One or both pupils fails to dilate or constrict to near or distant objects. Here may reflects problems with cranial nerve third or extraocular eye muscles. And patients with hyperthyroidism, exophthalmos also have poor convergence and sluggish accommodations not caused by advanced ages, which is due to the drug effect as from anticholinergic drugs. Next is the Perla. Here, note the pupil size and equality. Test pupillary reaction to light. Have patient look straight ahead while you bring light in from the side over the eyes. Note reactions and speed in both eyes. Normal direct reaction eye receiving stimulus construct the briskly, and consensual reactions opposite eye not receiving stimulus directly also constricts. And this perla should be round and equally bilateral, or sometimes sizes larger in children and smaller in older adults, and normal ranges 3 to 5 mm in adults, usually 3 mm, and in about 20% of the population unequal pupil ansocuria, and can be a normal variation, which is, and if normal the pupil react appropriately, and the difference is slight 0.5 mm, and shape is round, and normal direction and consequent pupillary responses to light is brisk constrictions to the pupil to about 1 millimeter or less. Deviation, which means a small pinpoint pupils, miosis like brain injury to the bones, use of the narcotics, atropine and other drugs, and larger dilated pupils, mydriasis like brain herniation, anoxia, or use of marijuana and mydriatic eye drops. And unequal pupil ansocuria. Here the third cranial nerve oculomotor damaged and dilated pupil ptosis and later deviations of affected eye, and unrelated brain herniations or increased intracranial pressure, and unilateral large pupil, tonic pupil that reacts to light slowly, benign eddies pupil. Unequal pupils affect affected pupil small but react to light and has ptosis on affected eye related to sympathetic nerve lesions, like for example Horner syndrome. This will be a very useful session, and the remaining parts will be seen in the next video. Thanks for watching.